If you're studying for nursing school or preparing for the NCLEX, respiratory disorders are one of the highest yield topics you'll encounter. Questions about asthma, COPD, pneumonia, pulmonary embolism, chest tubes, oxygen therapy, and ABGs appear frequently because respiratory conditions can become life-threatening very quickly. In this video series, we're going to simplify respiratory disorders so they're easy to understand and even easier to remember for your exams. We'll discuss the pathophysiology, hallmark signs and symptoms, diagnostic tests, treatments, nursing interventions, and NCLEX tips that can help you answer questions with confidence. Let's begin with a quick review of normal respiratory anatomy. Respiratory anatomy review. Before you can understand respiratory disorders, you first need to understand how healthy lungs function. Air enters through the nose or mouth and travels through the pharynx, larynx, trachea, right and left main bronchi, bronchioles, alveoli. The alveoli are tiny air sacs where gas exchange occurs. This is one of the most important concepts for the NCLEX. Inside the alveoli, oxygen moves from the lungs into the bloodstream. Carbon dioxide moves from the bloodstream into the lungs to be exhaled. Remember this: alveoli equals air exchange. Whenever you hear the word alveoli on an exam, immediately think about oxygenation. Many respiratory diseases damage the alveoli, fill them with fluid, or prevent air from reaching them. When that happens, oxygen cannot enter the bloodstream effectively. NCLEX tip: whenever a question asks why a patient is becoming hypoxic, ask yourself, is there a problem with ventilation? Meaning, can air get into the lungs? Or, is there a problem with gas exchange? Meaning, can oxygen actually move across the alveoli into the blood? This simple question helps narrow down many NCLEX answers. Signs of respiratory distress. Regardless of the respiratory disorder, many patients present with similar symptoms. Know these for the NCLEX. Common findings include dyspnea, tachypnea, wheezing, cough, cyanosis, low oxygen saturation, accessory muscle use, nasal flaring, difficulty speaking, restlessness. Here's a favorite NCLEX question. What is usually the earliest sign of hypoxia? The answer is restlessness. Many students immediately choose cyanosis. However, cyanosis is considered a late sign. By the time the patient develops blue lips or fingertips, oxygen deprivation has usually become much more severe. Asthma. Let's begin with asthma. Asthma is a chronic inflammatory disease of the airways characterized by reversible airway obstruction. That word reversible is very important. Unlike COPD, asthma attacks can often be reversed with medications. Pathophysiology. For the NCLEX, remember that 3 things happen during an asthma attack. Number 1, the airways become inflamed. Number 2, the bronchial smooth muscle contracts. This is called bronchoconstriction or bronchospasm. Number 3, the lungs produce excessive mucus. Think about drinking a thick milkshake through a tiny coffee straw. That's similar to what happens during an asthma attack. The airway becomes narrow, swollen, and clogged with mucus, making it difficult to move air. Common asthma triggers. NCLEX questions often ask what can trigger an asthma exacerbation. Common triggers include allergens, dust, pollen, pet dander, cigarette smoke, viral respiratory infections, exercise, cold air, strong odors, air pollution. Every patient has different triggers, so patient education is an important nursing intervention. Clinical manifestations. Classic asthma symptoms include wheezing, chest tightness, shortness of breath, coughing, difficulty exhaling. Notice I said difficulty exhaling. Many students forget that asthma primarily causes an expiratory problem. Because the bronchi narrow, air becomes trapped inside the lungs. Patients often describe feeling like they can't get the air out. NCLEX tip: if a patient with asthma suddenly stops wheezing during a severe attack, that is not necessarily a good sign. A silent chest may indicate that very little air is moving through the lungs, making it a medical emergency. This finding should never be ignored. Treatment: asthma medications fall into two major categories. Rescue medications: these provide quick relief during an asthma attack. The most common is albuterol. Albuterol is a short-acting beta-2 agonist that relaxes bronchial smooth muscle, causing bronchodilation. Simply remember, albuterol opens the airways. Controller medications: these reduce inflammation over time and help prevent attacks. Examples include inhaled corticosteroids such as fluticasone, budesonide. These medications are not rescue inhalers. Patients should continue taking them even if they feel well because they help prevent future exacerbations. NCLEX memory trick: a very common NCLEX question asks, which inhaler should be administered first? Always give the bronchodilator before the corticosteroid. Think about opening a tunnel before sending medicine through it. If the airway is wider first, the steroid can travel deeper into the lungs and work more effectively. COPD. Now let's compare asthma with COPD. COPD stands for chronic obstructive pulmonary disease. This is another high-yield NCLEX topic. Unlike asthma, COPD causes airflow limitation that is not fully reversible. Most patients develop COPD after years of cigarette smoking. Other causes include long-term occupational exposure, air pollution, chemical fumes, alpha-1 antitrypsin deficiency. COPD includes two diseases. For the NCLEX, think of COPD as two major conditions. Chronic bronchitis: think, too much mucus. Patients have chronic inflammation of the bronchi, causing excessive mucus production. Classic symptoms include productive cough, wheezing, dyspnea, frequent respiratory infections. A classic NCLEX clue is a productive cough lasting at least 3 months per year for 2 consecutive years. Emphysema: now think, destroyed alveoli. Instead of mucus being the major problem, emphysema destroys the alveolar walls. As more alveoli are lost, less surface area is available for gas exchange. Patients have increasing difficulty oxygenating their blood. Common findings include barrel chest, pursed lip breathing, weight loss, dyspnea, decreased breath sounds, tripod positioning. NCLEX comparison: here's an easy way to remember the difference. Asthma, reversible, triggered by allergens or irritants, bronchospasm, usually younger patients. COPD, progressive, usually caused by smoking, permanent lung damage, older adults. If you can distinguish asthma from COPD, you'll answer many respiratory questions correctly. Nursing interventions: as a nurse, priorities include monitor respiratory rate, assess lung sounds, monitor oxygen saturation, position the patient in high Fowler's position. Encourage smoking cessation for COPD patients, administer bronchodilators as prescribed, teach proper inhaler technique. Always remember that airway and breathing come before almost everything else. Part 1 Summary. Let's quickly review. For the NCLEX, remember these key points: alveoli are responsible for gas exchange. Restlessness is an early sign of hypoxia. Asthma is reversible. During an asthma attack, inflammation, bronchospasm, and mucus narrow the airway. Albuterol is the rescue inhaler. COPD is progressive and not fully reversible. Chronic bronchitis equals excessive mucus. Emphysema equals destruction of the alveoli. Smoking is the leading cause of COPD. Outrow. Great job. In Part 2, we'll cover 4 more high-yield respiratory disorders that frequently appear on nursing school exams and the NCLEX: pneumonia, tuberculosis, pulmonary embolism, and lung cancer. We'll break down the pathophysiology, hallmark symptoms, diagnostics, treatments, and the nursing priorities you need to know to answer exam questions with confidence. If you're finding this review helpful, be sure to continue with the next lesson as we keep building your respiratory knowledge one disorder at a time.